Well, good evening, everyone. Welcome to our webinar this evening on Anterior Composite Aesthetics. And we're going to talk about, honestly, two of probably the most important tips and tricks that I've learned to make my anterior composites really, really top tier aesthetics. For those of you who don't know me, I'm Dr. Ann Brady. I'm the Executive Director and Director of Education of the Pankey Institute, but I also am a practicing dentist. So my practice is actually in Glendale, Arizona, which is a suburb of Phoenix. And if you're confused, yes, the Pankey Institute is in Key Biscayne off of Miami, Florida. So the common joke is when people ask me where I live, I say in the Admirals Club. So we are going to launch into tonight's topic. So our topic tonight is really how to maximize the natural aesthetics and the gorgeous aesthetics of composites. But really, to start, I want to actually just talk about teeth and the reality that teeth look the way they do through a very, very complex process of different types of tooth structure, and light reflection and light refraction or translucency. And so, teeth are made of two different structures, both enamel and dentin. And then those two surfaces have varying thicknesses and various angles because of the shape of a tooth that create the properties that we see. The dentin is very thick in the gingival third of a tooth, and the dentin is where the chroma is, the color, the hue and the chroma. And in the gingival third, the enamel is very thin. As we start to move toward the incisal edge of a tooth, the dentin gets thinner and thinner in almost a triangular shape. The enamel is going to get thicker all the way to the incisal edge where we could have pure enamel with no dentin. And this creates what we call chroma gradient, the natural chroma gradient. So teeth look more chromatic, more colorful in the gingival one third, less in the middle, even less in the incisal. The interproximals, mesial and distal, are pure enamel, so they have less chroma. And so, when we think about what a tooth looks like, we have to understand that dentin is more opacious, enamel is more translucent, and different people's enamel have different characteristics of how they reflect or refract light. And so that makes matching what we're doing with composite really complex when we think about how to mimic all those different properties. When we think about a tooth matching perfectly, blending perfectly, we call it shade matching. That's really actually simplifying it way, way, way down beyond what it actually is. So, creating a pretty perfect shade match is actually about nailing all of these things. And I've got them rank ordered by importance. So the number one is silhouette, right? And so the outline form, the contour of a tooth, that's given by the three planes, gingival, middle, incisal, the emergence profile, the facial embrasures, the tissue, the dark color of the back of the mouth. Then you have surface morphology. And so a very, very smooth tooth reflects a lot of light back to the eye. A tooth with a lot of surface morphology refracts light away from the eye. And that actually impacts whether the tooth looks brighter, higher value, or lower value and more gray. So you can see value is the third one. Value is light reflectiveness. That's a combination of the inherent translucency or opacity of the tooth, the surface morphology, as we just talked about, the angle of the tooth, right? And so in aesthetics, we like to create reflective angles or angles that bounce light toward the eye. We don't want teeth retroclined. That creates what we call a deflective angle, and then the teeth look darker and more gray. And so there's a lot of things that go into value. Next is translucency, specifically the characteristics of incisal edge translucency. And then finally, at the very bottom of the list, we actually have what we typically think of as shade, which is chroma, color intensity, and then hue, which is the name of the color. In dentistry, we use letters. So A, B, C, D on a Vita Classic shade guide, RLM on more like the Vita 3D Master shade guide. right? And so you can see that truthfully the the actual what we call the shade or what we get off the shade tab, which is the chroma and the U in a classic system, and the value chroma and U in a 3D system. Um, those are all the way down at the bottom. And so, how do we create silhouette surface morphology? That's about us shaping the composite. That's about really understanding dental anatomy and using our hand instruments to sculpt the composite, a burr to shape the composite, and mimic what's going on with the other natural teeth. The probably the hardest thing of matching a composite is actually value, is light reflection. So I said dentin tends to be a more opacious material, enamel tends to be more translucent, and they're layered on top of each other in varying thicknesses. And then we have composites, and there are no composites on the market today that exactly match the translucency of enamel, even if they're called an enamel composite, nor match exactly the opacity of a dentin, even if they're called dentin composites. And so most of the time when we're doing a composite, the reason the composite is obvious to the eye, we can see it in comparison to the surrounding tooth structure, isn't because we missed the chroma and the U. It's because of the value. So if the composite looks too gray, we've made it too translucent, too low value. If the composite looks a little brighter, a little bit more opaque, it's because we made it too high value. And so really, if we can match the value perfectly, we're going to do a much, much better job of making our composites literally disappear so that we can't see where the restoration is in comparison to the tooth structure. So in this picture, I want always like to show this one. Obviously, tooth number 8 or the upper left central incisor is the one that's broken. This is a 16-year-old young man. He was roughhousing with his brother in a pool deck and hit the concrete and busted up his front teeth. I did not do the composite that's on there now. He went to an emergency dental facility, and they just put some composite on there to sort of cover it up because it was sensitive to him. There is some composite on the other central, tooth number 8, or the upper right central incisor. And that's composite that I put there as a test at the very, very beginning of this appointment before I've even prepped the other tooth. Because I'm trying to test my composite materials so that I can see, it's light cured, see, did I match the value? Did I match the chroma? And did I match the U? Right. So I put this on there, I show it to the patient. I can pop it off. It's not etched or anything. It's just sitting there, and I can play with my recipe of composites before I've ever done anything else. And so, one of the things that I'm going to tell you, I highly, highly encourage is when you're trying to match the color of composite for a composite that's going to be through to the labial or the incisal edge in the aesthetic zone. You've got to do it at the front end of the appointment and put the composite on adjacent teeth or on the tooth you're trying to match. Light cure it, step back, look at it, take a photograph, and make adjustments to your recipe, right? Before you actually start to prep teeth. This is actually where you're going to be able to decide, can I do it with one increment of composite and match all three things, value, chroma, and U? Or am I going to need to do layers? And how many layers am I going to need to do in order to match value, chroma, and U? And so, this is exactly how I do my formula before I start, and then I do show it to the patient. So I actually um, take a photograph, hand the patient a mirror, show it to the patient, and I show it to the patient at the front end because of the phenomenon of dehydration or desiccation. And so, a really, really well done composite restoration will actually not match the teeth at the end of that clinical appointment when the patient goes up to pay, schedule their next appointment, they go look in the restroom, bathroom. The mirror. So we have to tell them that on the front end. As teeth dry out, their U changes. They could move between A, B, C, and D. They become less translucent. As soon as they're less translucent, the value increases, meaning they look brighter and whiter, more light reflective. And then the chroma decreases and they look more colorful. right? So if we think about a composite at the end of that clinical appointment where we placed it, it should look a little more gray or low value. It should look a little more colorful than the tooth around it. And then we have a good chance that it'll actually match in about 3 days, 4 days when the tooth fully rehydrates versus matching at the end of that appointment. So we can't evaluate our recipe of our color choices in the composite at the end of the appointment when we're actually shaping and polishing. We have to do it at the very beginning. So that's a really important, um, piece of information, but it's also an important conversation to have with the patient. So what's probably my number one trick for matching composites? And that's understanding um, just a little bit about our neurophysiology and how we sort of trick the brains of people who are going to look at those teeth, right? And so our brains, our eyes and our brains are really, really good at differentiating the value, chroma, and U of two things that are butted up against each other, or what we call in dentistry a butt joint. Okay. We can literally see that differential and we can actually find where they touch each other, which is what we call the margin. Okay. Our brains get way less good at differentiating that, and they actually start to blend the two varying materials. If we have the solid material A, and we'll call that tooth, okay, and solid material B, we're going to call that composite. And between those two things, we actually have a zone where tooth and composite are layered on top of one another, and they're in changing or triangular shaped thicknesses, right? So the composite is a bulk of composite. And then there's an area where it's getting thinner and thinner and thinner, but it's laid on top of the tooth structure. So, how do we do that? In dentistry, we call that a bevel. And I like to think about bevels as a blending zone. So, one, you need to prep the tooth with a bevel. So, any surface that's on the labial in the aesthetic zone, you can do this on the occlusal table of your posterior composites if you really want the margins to completely disappear, create a chameleon effect. You're going to put a bevel. And the longer the bevel, and the more dramatic that thickness taper is, the more that the two different materials will start to blend together and look similar in value, chroma, and U. The other piece that we're going to use to our advantage is the fact that composite can actually be thinned down to what we call an infinity margin. So you can actually thin composite down to literally hundredths of a millimeter. And as long as it's bonded to the tooth, it's not going to chip or break or become fragile. So not only are we going to use a long bevel to help with this, but then we're going to think about when we're actually etching. And so on the labial of a tooth in the aesthetic zone, I actually etch the entire labial. I don't even think to worry about where's my margin end, where does my bevel end. I want phosphoric acid if you're using that, or your self-etching adhesive. I want it to go way beyond where my margin is stops based on the prep. And literally to me, I just do the entire labial surface. And then when I'm actually placing that last layer of composite on the labial, I don't worry about stopping the composite right where I think my bevel ends or my blending zone ends. I actually take my plastic instrument and I actually move that composite way out over the labial of the tooth, thinning it as I'm getting further and further from the prep. And then I know I'm going to thin that back to that literally hundredths of a millimeter, that infinity margin. When I'm using my fine diamonds, my sandpaper discs, my diamond discs, I don't even actually know when I'm done how much composite I have that's well beyond where I actually did my blending zone, but it's got to be bonded for this to work, which means you've got to etch well beyond that and you've got to apply dentin adhesive well beyond that. Which again, for me, whether it's a class 3 that comes through to the labial, I'm doing a class 4 incisal edge repair, I literally just do the entire labial surface of the tooth so that I never have a worry about that. And if you're accustomed or you've ever seen that sort of brown stained line that occurs around anterior composites. That's actually because composite was actually put beyond the zone where it was etched and bonded. So there's been composite that's gone out past the margin or the bevel on the of the prep, but it wasn't actually able to be bonded to the tooth surface because it wasn't etched and there was an adhesive placed there. And you can literally stain gets just under that little thin edge of composite, and then it holds there, so you get that dark stain. So probably number one trick for beautiful anterior aesthetics with composite materials is long bevel, etch well beyond where you end your bevel, taper the composite out there, and then thin it down to a really beautiful, what we call an infinity margin. Okay. And trick number two, which is really what we're going to spend the rest of our time together talking about, is that the value is the most important thing to match. Value is way more important than chroma and you. And value comes down to when we're talking about composite, the value is the inherent light properties of the composite material, right? So on a scale of 100% opaque to 100% translucent, okay, can we match that translucency versus opacity or light reflection using composite that we have in the tooth between the combination of enamel and dentin? And then the second part of value is creating the surface morphology. Okay. But the biggest, trickiest part of this is matching the material. And so I'm going to show you two of these graphics. This first one is a beautiful anterior composite from Ivoclar that's called Empress Direct. It's actually one of my favorite composites to use in the anterior. And this graphic is one that a lot of you probably have never seen, but every sales rep for every dental manufacturer has this graphic relative to their composites in a PowerPoint that they got from corporate marketing someplace. And this honestly is the most important piece of information that you need about whatever composite you use to do anterior restorations. Doesn't matter in the posterior. Truth of it is in the posterior. If I had to guess, I'd say 80+% of all the posterior composites in this country are done with one shade, and it's probably A1, A2, somewhere in there. And that often as dentists, we don't even know what shade we're doing in the posterior because our assistant picks it and puts it out. So you don't need this data, to do an occlusal on, a second molar, but you do need it to do a really exquisite job of matching in the anterior. Okay. So we're only going to look at the top row, the one that's named front lighting. And in every anterior composite kit, you're going to have 2, 3, or 4 different labeled types of composite. Okay. In Empress Direct, the two main are the dentin composites and the enamel composites. And then they have what they call their characterization composites. You can see two here, clear and opal. And then they have Empress Direct stains, which we'll talk about. So there's 4 categories of composite that come with the Empress Direct kit. This is a standard in dentistry. All the manufacturers that do this, actually, these are 1 millimeter ingots of cured composite. They put it over some sort of a card that has writing on it, some combination of black and white, and then they light it, and then they actually see how much you can see through the composite, right? And so you can see here, it's really obvious that in the Empress Direct system, any tube where it says dentin is actually a very opaque material. It's actually more opaque than actual dentin. And you can see if I said to you, how opaque, is the dentin, how much of the word Empress Direct can you see through the 1 millimeter composite? I would hazard that that composite is probably in the range of 85, 90% opaque. We can see very little of the words Empress Direct. Then we look at their enamel composite. Their enamel composite is actually maybe 50-50. We can see half of it. That's still less translucent than real enamel. And then we have the clear and the opal, which are really translucent. We'd almost say they're 80% translucent, which is way more translucent than real enamel or real dentin. And as I said, none of the composite systems mimic the translucencies of the actual tooth structure they're named after exactly. Okay. So, this system, the Empress Direct system, is actually pretty close for those of you who use Filtech Supreme. What they call their body shade is pretty much equivalent here to the dentin opacity, their enamel shade, and then they have characterization. All right. So if I'm going to use this material so that I'm going to mimic the tooth structure, I have to decide how high value is the tooth, how light reflective is the tooth, and then I'm going to need to layer some combination of 2 or 3 of these layers in order to get a composite restoration that has the relative translucency or opacity of the actual tooth structure. Okay. So you've got that information from looking at this. And then we're going to look at a different system. So this happens to be the Genial Composites, Genial Sculpt from GC America. So what they have in this system is they have composites they call their opaque composites. They have their dentin shade composites. Then they have their enamel composites, and then they have some specific bleach shade composites. So if you look here, if you look at the very, very bottom row, you can see on the left-hand side are their opaque shades, AO1, AO2, AO3. And I would say those are in the range of the opacity of the Dentin and Empress Direct, but maybe a little less opaque. Probably the most opaque composite on this card is actually the bleach, the XBW. Okay. Then you have your dentin shades in this system, and the dentin shades in this system have probably kind of a similar opacity to the enamel shades in the Empress Direct. And then you have the 2 enamel shades. They call it JE and AE, juvenile enamel and adult enamel. And those probably have the relative translucency to opacity of the opal and the clear shades in the Empress Direct system. So they still have 3 composites that have the sort of the same relative opacity and translucency, but they give them totally different names, right? In the Genial Sculpt, the opaque is the equivalent of the dentin in Empress Direct. The dentin shades are the equivalent of the enamel shades in Empress Direct, and the enamel shades are the equivalent of the characterization shades. So you have to know your system. And so I would highly encourage the next time the manufacturer rep is in not your Shine or Patterson or Benco, not your distributor rep, but the actual manufacturer rep for the composite that you use for your anterior composites, that you actually make a request that you would like this graphic, which again, they have in a PowerPoint typically that they got from corporate, from their marketing department, so that they understand the aesthetics of their own composite. And all you need is that one slide or this one graphic. And it's going to go an immense way at helping you understand how to layer the composite you already own so that you can actually better match the light properties of a natural tooth. And so when we think about those composites, and every composite system that's manufactured for the anterior has those multiple categories of composite in the kit that have different relative opacities versus translucencies. And you just have to figure out their names. So some systems have a composite they call the opaque. Again, in Empress Direct, it's called dentin. In Filtech Supreme, it's called the body. Some systems come with very specific bleach composites, and those do tend on the opaque side, which is really interesting to me because I have lots and lots of teeth that have been heavily, heavily bleached, and they're almost impossible to match because they're so translucent. Like you would do the whole thing just with the characterization shades or just with the enamel shades in the Genial system, right? But then you also have composites that are going to create the Chroma and the U have the relative opacity of actual real dentin. So you need to understand what these 4 categories are like in your system. And then all you need to do is you need to figure out what's my recipe. Can I do it with one layer? There's one layer of my composite kit that matches the value, the chroma, the hue, and the enamel characteristics of this tooth perfectly. And that's true. That may sound like, really, that never happens. It does happen. There are some natural teeth that are fairly simplistic in their aesthetics that can be really well matched with just one tube of composite, especially if you've done a really nice bevel or blending zone and you get that infinity margin. And then on the other hand, there are teeth that are really, really exceptionally complex in their aesthetics. And you might actually need four layers, one from all of these different categories. And you have to vary the thickness of these layers to actually replicate the natural tooth structure. So you got to have all of these available, and then you got to sit and figure out your recipe. And that's actually what I was doing in that slide before I ever started to prep the tooth. Right. So the most lingual layer of the tooth. So if it's a through and through class 3, the layer that's going to be on the lingual, class 4, incisal edges are a little different because if it's a true incisal edge, it may be translucent through and through. But if you need to put an opaque composite, if you need to put a bleach shade, because the tooth you're matching is reasonably opaque, higher value, is bouncing a lot of light, you always want to put the most opaque composite on the lingual side of the tooth or to the lingual of the preparation. Okay. So it becomes the lingual wall of the restoration. Okay. This could be an actual opaque composite. So I'm showing you here one of my favorite opaque composites, which is from Venus Diamond. And they call them their opaque chromatic shades. In the genial sculpt system, it could be one of the opaques or one of the bleach. And in the Empress Direct system, it would be the actual dentin composite. In Filtech Supreme, it would be the body composite. It's going to go all the way on the lingual side of the preparation. And it needs to be within the confines of the final restoration. How thick are you going to make this layer? It depends. How opaque do you need this restoration to be? How much light do you need to bounce? Probably the thinnest I would do this layer is 3/10, 5/10 of a millimeter. But this could be a significant thickness. The thicker you make it, the more opaque it's going to get, and the more light it's going to bounce. So you play with that when you create your recipe. Okay. This layer doesn't necessarily provide any of the chroma and the hue. It might, but it doesn't arbitrarily have to. Okay. So what you're going to now put in the center of the restoration or the center of the preparation where the actual dentin would be in the natural tooth, okay, is what's going to provide the chroma and the hue. Okay. And so this is going to be chosen because you need A1, B2, C4, and it may do double duty at providing some opacity, like if you're in the Empress Direct system or the Filtech system, and it may not. It may just be providing the chroma and the hue, and you put something to the lingual of it to provide the opacity or stop the light so that it bounces back if you're using a different composite system. And then now you should be left with about a 0.5 millimeter layer that's on the labial of the final restoration. And again, within the confines of the restoration, not bulked out on top so that you're going to trim it all off. Okay. And this is where you add characterization, staining, and you want to really mimic the look of natural enamel. Okay. And so, here what we're going to do is we're going to decide, do I need, opal, translucent in the genial sculpt system, the juvenile enamel, the adult enamel. This labial 0.5 millimeter of composite is going to be very translucent because it's really mimicking the natural enamel. And it's you might even want to choose a specific type of a composite called a microfill because it's highly polishable. Okay. And so you may just go with a characterization composite. Okay. If you want to do staining, staining is done on top of the layer of composite that replicates the dentin before you layer on the enamel. Never put custom stain on the actual labial surface because it won't last. You'll trim it off when you trim the composite or polish the composite. And even if you try to put it on after you've done your trimming, you've created your surface morphology, the patient's going to toothbrush it off. Okay. So if you're going to do decalcification spots, you're trying to put like a crack line with a little brown stain in an older patient. You're going to try to use a little blue or lavender to create incisal edge effects. That's going to go internal by about a half a millimeter into the restoration. Lots of great kits for this. The Empress Direct Color is fantastic. The OptiGlaze kit. You pick the one you like. They come in different viscosities. If they're very low viscosity, you layer them and you keep adding layer to make the color more intense. If they're higher viscosity, you actually dilute these with your dentin adhesive or with a clear. The systems come with a clear you can use to dilute. Um, how are you going to apply these? Believe it or not, most of the time, you're going to use the end of like a number 10K file from endodontics. Even if you don't do endo, you need a little file for this. You're going to take just a tiny bit of the color off of a mixing pad. You're going to put it onto the pre-cured composite that's replicating your dentin. And if you want, you can now take a micro brush and you can just touch it before you cure it. It kind of creates a sort of a spider webby sort of appearance like decalcification spots have. So instead of it looking like a polka dot where you put it from the applying it with the endo file, you pick a little bit up with a micro brush and it sort of gets this sort of a cloud like sort of a spider webby look like decalcification has. So lots of things you can play with composite stain. And then if you've stained, you're still going to now put your enamel composite on top of this layer, right? Whether that's opal or translucent or whatever you're going to put on top of it. So this is basically trapped in between those layers of composite. And then what you've got to do is you've got to do all your sculpting, right? So you put on your enamel layer, and then you're going to do all of your sculpting. And so, again, you might need all these different layers I've talked about. You might need two of them. You might be able to get away with just one of them. I've done that. It depends on the complexity of the tooth you're trying to match. Okay. So I want to just sort of show you sort of doing this. I'm going to do it in two different ways. I'm going to do it just on a matrix, and I'm going to almost make a shade tab out of composite, but then also doing it on a tooth. And because you need to layer these, and because you need to have these layers be within the confines of the tooth, when I'm going to do this kind of layering, I typically do have a silicone matrix that is made off of a model of a pre-op model of the tooth or a wax up if you're changing things, so that I have something to layer against. Okay. And so you can see this in here in this slide, the silicone matrix. How do you do it? You actually put the lingual layer of composite onto the matrix on a tray table, and then you seat it against the tooth. Now, remember, this most lingual layer, probably 3/5 of a millimeter, is what's going to stop the light. It's what you're using to create light reflection or opacity. You're going to notice when I've done it in the clinical photograph that I'm not bringing it through the interproximals because the interproximal of a natural tooth is more translucent. So I don't want a highly opaque composite. So you put it on, you light cure it, and now you're going to layer all of your other composites against this layer. You can actually now condense against it. You're going to build moving to the labial until you finish with your enamel layer. Okay. So the next layer we're going to add is going to replicate the dentin of the tooth. It's going to be responsible for adding the chroma and the U. right? So if I need an A3 tooth, I'm going to use something that's got A3 chroma and U, and I'm going to apply this. And what I want you to notice, like I said, I'm doing this just on my in my hand in these photographs because I'm going to build a shade tab. But when you do this layer isn't an even thickness from gingival to incisal edge because anterior teeth, the dentin is not the same thickness from the gingival to the incisal edge. This is a tapered layer. It's a triangular layer, and this layer is at its thickest at the gingival of the cavity preparation, and it gets thinner and thinner as you go toward the incisal edge. You may do one composite here, or if you're trying to create chroma gradient, if you've actually got a preparation that goes pretty far down the tooth, you may do one layer of an A3 and then you may add another layer. And again, it's triangular, it's getting thinner. Notice that I've stopped this layer 1.5 millimeters short of the incisal edge. I would do that in a young person where I'm trying to match an all enamel incisal edge layer. I've actually used a plastic instrument. I've incorporated what we call the lobes of dentin so that you're going to be able to see that through the composite to mimic nature. And then you're going to light cure these layers. Again, notice my dentin colored composite is not all the way to the interproximal. That should be pure enamel. So I'm staying away, which means if I was doing this as a class 3, I'm not actually building up the contact. That's going to be the last thing I do when I put my enamel layer on. I'm building in my dentin toward the center of the tooth, the center of the cavity prep, and the last thing I'm going to do is I'm going to make sure that I pack composite or place composite against that mylar strip so that I'm building that contact in an enamel shaded translucent composite, which is then the last layer that we're going to apply over the top and into the interproximals. So now we've got this layers that replicate what's happening from a natural tooth perspective. And so, if we're thinking about doing that from a clinical perspective, and this happens to be a young patient had a car accident and went through a windshield, and we're trying to just get these teeth so she can go back to school. Why in this case did I actually almost veneer the labial of this tooth? Because that's definitely taking my concept of a long bevel and a blending zone pretty much as far as we can take it as a prep. I've actually done like a 3/10 of a millimeter, 5/10 of a millimeter veneer prep on the portion of the tooth that she did not fracture. And I did that because if you look at her natural teeth, you're going to notice that she has lots and lots of these sort of mesial to distal bands of decalcification and of color. I'm going to try to build that in with some stain when I do this composite. But it's if I just did it at the fracture line, it'd be sort of like trying to line up striped wallpaper, and it's really difficult to do. So I want to be able to carry that from side to side myself. So the complexity of her enamel is what prompted me to do more preparation than I would need to do normally to do a composite like this. We're turning it into a composite veneer. And I don't feel like that's overly aggressive in this case because ultimately at some point in the future she's going to end up with ceramic restorations on these teeth. So these are I hope long-term composites they've turned out to be, but at some point somebody's going to prep this tooth for a crown anyway. Okay. But the first layer, I've got my silicone matrix. This one happened to have been made off of a model we did a little waxing on so that because I didn't have a pre-op model because it was a trauma. And the first layer we put in there is the lingual. And notice I've put the lingual where that through and through class 3 was. I've put the lingual all where that entire class 4 fracture was. And now this layer is light cured. And it's the layer that's chosen for its opacity, its light reflection, and now it's going to bounce light to help me create the the appearance, the value of the natural tooth. And again, I've stayed away from the actual contacts. I haven't built up the contacts or the interproximal because I want to do that with a translucent enamel based composite. And also, you need to put mylar strips in there, and we need to actually make contacts. Now, what I'm going to do in this case is I'm going to add where I need dentin, right? The composite that I add actually should be a pretty exact match to the Chroma NU of the dentin we can see in the natural tooth. And I'm not going to come all the way to the incisal edge. This is a 16-year-old patient. And you can see if you look at the adjacent centrals, she's got a pretty nice 1.5 millimeter band of just pure translucent enamel on her incisal edges. If I look at her centrals, she doesn't have super dramatic like lobes of dentin, but a little bit. So I'm going to basically, if I use my mouse, I'm going to add dentin composite, and I'm going to stay away from the interproximal, and I'm going to come about 1.5 millimeters, and I'm going to shape it. And then I'm going to come back down here, and that layer is going to be pretty much the same thickness as her dentin here. And it's going to taper off and be very thin, maybe 0.5 millimeter as I approach the incisal edge. And then I'm going to light cure it. Okay. Then I'm going to take my white stain and I'm going to create those sort of decalcification, that character she has in her natural tooth structure. And then I'm going to cover it with my enamel layer. That's when I go into my interproximals. Now I'm going to shape it, add my surface morphology, and then we're going to polish it. Okay. And so if you look, this is the final restoration. This chroma gradient in the gingival 1/3 is her natural tooth because my enamel composite is so thin. This translucency, just like in her natural tooth, is because my incisal edge is pure enamel composite with no dentin. You can see where I ended the dentin composite there because it's more opaque. Okay. And that it's not a sharp line across, right? It's got that character of dentin. You can see where I'm adding in surface morphology. She doesn't have a lot of natural surface morphology. So I'm just keeping this reasonably smooth. Okay. And then add that silhouette, that contour, and polish this up. Okay. So, do I do that with all those different steps and all of that complexity in every anterior composite? No, because not every natural tooth really requires that. But I figure it out again by using my recipe. I knew what color composites I was going to use. I chose them. I had them already out, how many different layers I was going to need to do. And I did it by matching it on her other central before I ever did anything else. Okay. Right now, this is the immediate post op photograph. The whole composite looks a teeny bit more gray, lower value than her central, and it should because her natural teeth are dehydrated. Her natural teeth right now look a little less colorful and a little brighter and whiter than they will in a couple of days. And that's exactly what we aim for. And I do need to post-op her. So all of these kinds of composites, this patient is already scheduled back with me to come back in about 72 hours so that I can evaluate the final aesthetics, take some new photographs, and we can make adjustments if we need to at that point. I could just remove one layer, the enamel layer, or I could just remove the lingual layer if it's not opaque enough, and I could still bond to the other composite because I still have monomer. Okay. So that's really that thought process. And so I wanted to share with you tonight those two things that really transformed anterior composites for me. One is that idea of a long bevel blending zone and etching the entire labial surface. And the other is that the most important thing to match is the value or the light reflection, more so than the chroma and the U, so that we really get a beautiful aesthetic match. All right. Well, thank you everyone for being with us.